Welcome, and thank you for joining us today, whether you're live or on the recording for episode 6 of Dr. Jeff Talks About Sex and Intimacy, Empowering Women Post-Menopause. I'm so honored you are here with me to learn more about this topic tonight. Oh, please join us on social media. You can see all the different ways you can join us. We are out there on Facebook, YouTube, X, and all your favorite social media sites. And please like us, share, or follow us on your favorite social media. You can also go to our website, and on our website, you can find the Facebook link. And we are looking for you to follow us on Facebook so we can share things live with you. So follow us on Facebook. On the website, you can learn more about upcoming episodes. You can watch past episodes, all those great things that you can learn. But we really appreciate if you find us on social media and you like, share, or follow us. Once 100 people are following us on Facebook, we can have our live stream there. So thank you for all of that. Oh, and don't forget, you can listen to us in your car now, podcast or Spotify, lots of different ways to follow us. So don't forget, you can listen to us, our audio, and we have had over 1,000 people listen to our show. So thank you, all of those who are listening. We really appreciate it. All are welcome here. All are welcome. You are welcome, whatever your sexual orientation, your gender identity, or your relationship style, you are welcome here. Every Tuesday, we're here at 7 o'clock. The goal is simple, to enlighten and inform you. And we're using evidence-based information to improve your sexual health, to deepen intimacy with your partner, and to enrich your relationships. Menopause. Oh boy. Menopause is challenging. Menopause does a real number on some women's sex life. We can have vaginal shrinkage, also called atrophy. We can have dryness, hot flashes. Lots of different things can come with menopause. Even some of my younger female patients will struggle with things like vaginal dryness and atrophy. And we're going to talk about that a lot this evening, and we're going to delve into that with our guest speaker. So I'm really excited to do that with you this evening. But a few thoughts before we start. For many of us, the feeling of not being enough, of being flawed or broken or defective or deficient or unworthy lurks just beneath the surface in our lives. Doesn't take a lot to trigger that. Doesn't take much to trigger that. Could be hearing about someone else's success. It could be facing a disagreement with a loved one, making a mistake, or being criticized, and that triggers it. These moments can feed that false belief that we are unworthy of love and acceptance, making it hard to trust that we are all truly valued. When we carry this doubt, it becomes difficult to even relax, to feel at ease in our own skin. But here's the truth. You are not broken. You are not deficient. You are inherently worthy. Your struggles do not define you. They are simply a part of your journey. You are so much more than your challenges. And as you free yourself from that weight of unworthiness, you step into the fullness of who you truly and inherently are. I am so excited this evening that our guest is joining us. Our guest is Dr. Margaret Amy Hull. She has over 20 years experience as a woman's health nurse practitioner. Specifically, she focuses on female pelvic medicine at the Center for Pelvic Health. She is an associate professor of clinical obstetrics and gynecology at Vanderbilt University. She has a wealth of knowledge on this topic this evening, and I am so happy and honored to have her here with me this evening. And she's also just an amazing human being and my friend. So thank you so much for joining us this evening, Dr. Hull.
Hi, Jeff. Thank you so much for having me. I appreciate it. And thank you for that wonderful introduction. You're just doing such fantastic work and really getting a lot of great information out there to people. So Just wonderful, wonderful, and keep up the great work. Um,
Thank you. Thank you. And thank you so much for sharing this evening with us and being willing to share your expertise in this area, because this is something our listeners have been asking for and they really want information on. So let's dive right in, because I'm excited. I've seen what you're going to present, and I can't wait for our listeners to hear.
Well, thank you very, very much. Thank you so much. So just as Jeff said, we're going to be talking about specifically the post-menopause period in our lives, and specifically talking about the menopausal symptoms of vaginal dryness and hot flashes. We know a lot about those if we are getting into, even in our 40s, where we're not quite menopause, but what we call perimenopause, where we're starting to maybe see some of those changes. So I think a lot of women hear about this, but maybe don't fully understand what everything means and how everything affects not just them physically, but also affects them within their everyday lives. So without further ado, I'll go ahead and get started. I think I'm supposed to hit.
Yep, you can
There
hit
we
those
go.
buttons.
There we go. Well, I do have to make sure I do give my disclosures. I do serve on a clinical advisory board for Coloplast, so I do want to make sure that I give you all that information before I go any further. So let's start by diving into some of the definitions. It's super important that we start from a foundation of understanding correct terms, correct terminology. And so I did want to make sure I lay that groundwork. NAMS is the North American Menopause Society. They're a scholarly organization full of wonderful, wonderful people who work specifically in this field, helping women with menopause. It's important to understand that menopause is normal. We sort of attribute abnormalities to it, but it really is a normal phase in a woman's life. And thankfully, we live longer nowadays. And so a lot of women live longer beyond that menopausal age. And so certainly can see a lot of the effects from it. The complete full definition, if you will, of menopause is the ovaries ceasing production. So they stop working, and it has to be for a minimum of 12 months. And so women essentially are without a menstrual cycle or a period for at least 12 months. If we hit that, and if we're around the ages of 40 to 58, very likely that could be menopause. The average age of menopause is approximately 52. Again, it can vary from 40 to 58. Anything less than the age of 40 is actually a different issue that we call primary or premature ovarian insufficiency or failure. Completely different issue. Symptoms are very similar, but very important to understand that that is not technically menopause. And I have a lot of patients tell me, oh yeah, I stopped having periods when I was 38. I went into menopause when I was 38. It's really a little bit of a different issue and requires evaluation and management with a skilled provider who can help navigate women with that. So super important to understand that. Our 2025 estimates of the women who are in the menopause worldwide, we believe there's as much or greater than 1 billion women. So it's a lot of women entering that phase of life. And so a lot of women potentially with these concerns. It's a constellation of symptoms affected or created or felt, and can affect women just in minor ways, moderate or severe ways. Everybody's different, and their transition into the menopause is very different. It includes specifically what we're going to talk about today are the vaginal and urinary tract changes that occur. We're not going to delve into skin and hair necessarily, but women do notice changes when they go through that change in life. BMI stands for basal metabolic index. And so we do notice that we can gain some weight when we go through the menopause. We won't be touching on that so much, or cognition, but again, it's a constellation of symptoms. Super important that I impart to y'all that it affects many, many systems of our bodies. All right. So again, super important to remember it is a normal process. Okay. All righty. So we have lots of different terms that menopause has, I don't want to say menopause conjures, but that we have conjured up for the menopause. Again, it's super important to understand that it is a quality of life issue. While it is normal, it can very much negatively impact our quality of life. We've heard lots of different terms over the years. Vaginal atrophy, that just sounds bad. Atrophic vaginitis, that makes it sound like it's some sort of infection. It's not, and that's again something that thankfully I think the nomenclature has changed. In 2014, some scholars that work in this area convened and decided we need to change the nomenclature, and so they came up with a term called the genitourinary syndrome of menopause, or GSM. So gone are the terms atrophy, vulvovaginal atrophy, atrophic vaginitis. We still see those terms, we still use those terms clinically, but the new term is now genitourinary syndrome of menopause. So again, a constellation of symptoms that create that vaginal dryness, that pain with intercourse, that irritation. We also are going to talk about hot flashes, night sweats. You hear them all. The correct term that we use in my world is vasomotor symptoms. So vasomotor symptoms, or VMS, equals hot flashes, night sweats. And they can hit you really fast and be super intense and super uncomfortable. And so they are quite problematic as well. So I'm going to keep moving on. So what is genitourinary syndrome of menopause? We'll start with that first. Vaginal dryness, okay, painful sex. We'll start with that one first. Again, a constellation of symptoms often includes painful intercourse, dryness, irritation, burning. You might have irritation on the outside of the vagina called the vulva, and you may have inside the vagina irritation. Urgency of urination. So this affects the bladder and the urethra as well. So you may get urgency of urination. You gotta go. You may have urinary incontinence. You might start to develop urinary tract infections. And we'll talk about that a little bit more in detail. You may have some abnormal discharge. Some women will say it's very watery. Some women will say it starts to become pinkish, tinged, brownish. All kinds of different colors that can be associated with GSM. Sometimes women will have vaginal bleeding or spotting, not because there's something wrong with the uterus, but because the vagina, as it does become more irritated, it can become weepy, and you can have little micro tears and bleed from those micro tears. So women will notice that pinkish, brownish, maybe even actual spotting, bleeding symptoms. Again, the systems affected are the lower urinary tract, the vagina, the vulva, and the perineum. That's the area outside the vagina that also is skin that is before you get to the anus or near the anus. So all that outside area can be affected. You can see anatomic and physiologic changes, where we essentially are transitioning from a state where we're producing estrogen to a state where we're not producing estrogen anymore. So things start to change because they start to lose that influence of the estrogen. The estrogen's influence is no longer there. We start to see collagen deprivation. So women start to tell us, yeah, I got more wrinkles when I went through the menopause. Things started to sag. Things changed because, again, we do have collagen, normal, unfortunately, deprivation that occurs. We'll see these changes also because we start to see reduced vascular supply. So maybe sensations change. They don't feel things like they did because we don't have the blood flow perhaps that we had prior to the menopause. And then we have that hallmark thinning of the vaginal skin, what I call the vaginal skin or the epithelium. We go from a very thick, robust state that's very flexible and pliable to a much more thin state that does lend itself more towards that irritation. All right, I'm going to keep on moving along. So it's super common, important for women to understand. Again, this is a normal process. Doesn't make it okay. It's quality of life impacting. Unfortunately, super common. So y'all are not alone. We are not alone. It's unfortunately, though, often underdiagnosed. And in my world, we talk about it a lot. Why is it undiagnosed? Is it because we're not asking the questions, or because women are too afraid or too ashamed to bring it up? It's on me to ask the question, though. So hopefully all of the providers out there are asking you the question. And if they're not, I want to empower you to have your own back and bring it up. It's okay to ask. It's important to ask about it. Now, GSM, unlike vasomotor symptoms, does not resolve over time. It gets worse as we continue on in life in that hypoestrogenic state. That vaginal atrophy, these symptoms that can occur, don't resolve, don't get better. And so it's important to understand that unlike the vasomotor symptoms, they don't go away. GSM doesn't go away. It's super common. We have, though, a wide range of estimates, and we don't understand that, as low as 10% to as much as 66% of women. So again, are we asking the right question, or are women just afraid to say or speak up that they're really bothered? I happen to think it's not 10%. I think it's definitely closer to the 66% and maybe even more than that. And because it's underdiagnosed, because we don't fully understand the prevalence of it, it's often inadequately treated. We do see from a 2016 study by these authors below that it's often treated or diagnosed 50% of the time in women receiving treatment, but we think as much as 79%, more than 79% of women are bothered. So there's definitely a huge number of women out there not being treated. So what is happening to the vagina? Again, it's thinning. This is a really nice picture that I think gives the sort of light bulb opportunity for us to see where the vagina changes. It goes from a very thick layer of different cell layers to just one sort of specific layer. We lose those very thick superficial cells, and all we have are these intermediate parabasal cells and a very, very, very small, thin layer of superficial cells. And so you can see where we lose that cushion, we lose that thickness, and along with that, we lose the ability for the vagina to lubricate and for it to be healthy, potentially healthy. So now, what are vasomotor symptoms? Again, the hot flashes, the night sweats. We've heard them called hot flushes as well. Those are quick, they're rapid, can last as little as 30 seconds to as long as several minutes. We often see that these can affect women during their day, but because we call them also night sweats, we see that they affect women at night when they're asleep, often causing women to lose sleep, waking up. So sleep deprivation can occur because of these. It is super common concern. Women often do vocalize this concern. It may be because it's a little bit more acceptable to talk about hot flashes than it is to talk about vaginal dryness. We do see as much as 75% of women are affected, and the variation in time can be as little as 6 months to as much as 2 years. But what we do see is that as women advance into that menopause state and their body becomes more adjusted into a new normal, these symptoms typically resolve. But there is some evidence that that there could be as much as 10 years that women might be affected by vasomotor symptoms. Suffice it to say, that's a smaller number, we think, that women are experiencing this beyond 2 years, Majority of women, it's 6 months to 2 years with hopefully symptom resolution as time goes on. So yeah, we see a lot of cartoons about this. I printed these. I wanted y'all to have those. One, because, okay, yeah, it's funny, but also to know that it's out there. There's a lot of people talking about it, and so it's a super common issue. And the one at the bottom left here, no batteries are needed, but you have to be menopausal to make these hot flashlights work. I thought that was kind of funny. It's just like, when you see the woman there, she's just kind of like, okay, whatever. So I want to dive in real quickly into treatment options for GSM and vasomotor symptoms. And I'm going to start with the GSM since I started talking about it first. But what I want to impart to women is, don't be afraid to ask. As I mentioned earlier, have your back. A lot of people in this world don't have our backs. We got to have our own backs. So don't be afraid to bring it up. I hope that your provider is bringing it up. But if they're not, don't be afraid to ask the question. We really want to tailor it to women based on what's their most bothersome symptom. So treatment can be very individualized, and treatment can look like the way you want it to look. And don't be afraid to ask the question and really think about what bothers you the most. And because that can help your clinician figure out, okay, what do we need to do to help tackle the problem? Depending on the symptoms, it can be a very local kind of treatment to more of a systemic treatment, meaning absorbed into your body. So when I say a systemic treatment, I mean treatment that absorbs. Local treatment is just that, local. And again, depending on what bothers you the most might determine, maybe you just need local treatment, maybe you need more systemic treatment. It's important to discuss special considerations because we hear a lot of information out there in the world about who can have, for example, hormones, and we'll talk about that, who can't have hormones, and what's good about hormones and what's bad about hormones. Fortunately, the pendulum is swinging more to a balanced, centered approach. Hormones are not the panacea that we once thought. Meanwhile, they're also not a bad guy, and there's definite inherent benefit for women if they choose to be on hormone replacement therapy. But we do want to make sure that women are aware and talk to their clinicians about, okay, I'm on blood thinners. Can I take hormones if I'm on blood thinners? It's important to have a conversation about that. What are our risks for increasing us having clots? It's important to talk with your clinician about prior cancers. What I do want to make sure women understand, though, is that if you have a history of female cancer, it is not necessarily a deal breaker that you can't have hormone therapy, but it is an opportunity to really have a really in-depth conversation about the risks, benefits, and then figuring out what's that ratio and what's that look like for you. Cost concerns are a huge issue. There's lots of different options out there, not necessarily the most cost effective, and we'll talk a little bit about that. Certainly with advancing age, we do not recommend that women start something systemic as they get older, but it might be okay to do something local. So again, we'll talk a little bit about the difference there. We don't recommend women starting a systemic treatment, meaning hormone replacement therapy at the age of 60 or beyond, or if they are greater than 10 years post-menopause. So in that menopause period, when we're stopping our cycles and we're having these symptoms, certainly hormone replacement therapy might be an option. But if you're already in your 60s and you've been menopausal since you were 50, it's not really a good idea to start something systemic at that point. And we need to talk with you about, again, what bothers you, okay? All righty. So as I mentioned, there's hormonal options. There's also non-hormonal options, non-prescriptive options, and it can get super confusing for a lot of women. It can get confusing for you guys. I'll admit it can get confusing for me, trying to keep up with all the different products out there and really trying to understand what's doing what's helping what. But From the standpoint of GSM treatments, you can try over-the-counter lubricants, which are also like moisturizers. So your brands might be like KY Jelly, KY Liquid Beads, which are more like a suppository. Astroglide, you've probably heard of these products, Good Clean Love, Slippery Stuff, and on and on and on it goes. You can try products that are more oil-based, not water-based, but oil-based. And some of these products are natural-based, so like your unrefined coconut oil, your olive oils, even sweet almond oil, is an option. Some women use Vaseline, and then also from a brand approach, there's also something called Key suppositories. Again, these are oil-based products. Super important that I do make sure that I impart to y'all that your oil-based products, though, are not latex condom compatible. So it's super important to remember that you're oil-based. You might want to be more mindful of whether or not you're using a condom, and if you are, is it latex? Is it another type of material? And maybe you use something that's water-based, or you could use something silicone-based. Silicone-based products are compatible with your latex condoms, but you might want to be a little bit more mindful that your silicone-based products, you might not be able to use those in conjunction with vaginal sex toys, aid devices, things like that, especially those that because they might have the risk of degrading over time. So just be FYI. But your silicone-based products include like Lube Life, Uber Lube. I've used or had patients use Replens. So you name it, these aren't even all of them. And then you have the option of trying something called hyaluronic acid, and that's your Hyalogen and your Reverie. I've had patients use both of these products with good results. The sort of the take on hyaluronic acid and those types of derivative lubricants is that it's going to help with keeping the tissue more flexible, helping the tissue retain water, which might help with lubrication. We don't really know, though, if it helps with replenishing that vaginal epithelial layer, making it thicker again. But the idea around hyaluronic acid is it does help with tissue growth and thickening. So might be something that non-hormonal that might give benefit for women. I also want to talk about osmolality. We have lots of different information out there, and we talk about osmolality. The more hyperosmolar, if you will, if that's a word, it is. So the higher the osmolality, the more potential in theory, that there could be for tissue injury. And so we usually recommend something that's low osmolality, less than 300. Problem is a lot of our products over the counter have a higher osmolality, and so it makes us worry a little bit that could increase vaginal irritation, vulvar irritation, and a lot of contact dermatitis symptoms with some of these products if they are have a higher osmolality. So important to look at that, because a lot of these products we use and we could have skin problems with it, and then we're wondering, okay, what just happened to me? What's going on here? So I do want to make sure that's understood. Some of these products have a lot of preservatives in them. They may have things called parabens. They may have glycerols. Those are all preservatives, and some of those products might increase the risks for some vaginal changes in the vaginal environment and create odor and something called bacterial vaginosis, or BV. There's very, very, very limited information that parabens might be weakly estrogenic. And so, again, that kind of opens up the question and the discussion about the risks of cancer and those sorts of things. So again, it's important to remember, though, that this is not a lot of data, not a lot of information out there. So we do want patients to be mindful, women to be mindful of the product. And we certainly recommend something that's within a normal sort of pH balance, very, free of scents and perfumes and things like that. And then, just look at the osmolality on the product, or, what kind of preservatives do they contain? So we've got lots of different costs. This was an interesting cost comparison that I found on a website called Healthline. I double checked it the other day to see if it was still pretty consistent. And it seemed to be pretty consistent still with your cheaper versus your more expensive options, and as well as the pros and the cons and who it might work best for, and that sort of thing, and what you're looking for again. And so I did want to make sure that you understand the FemiClear is, I've not really had a lot of patients use that, but it's a feminine wash, supposed to be pretty inexpensive. And if you're worried about odor or things like that, that's supposed to be pretty gentle. But the con is that it can irritate the skin potentially. The KY liquid beads, again, that is a suppository form of a moisturizer. The others are more gel type options that you can use. So other non-estrogen options, but prescriptive. So these are no longer over-the-counter options that I'm looking at for this issue. Is DHEA, that's called Intra Rosa on branded DHEA inserts, twice a week use. The idea is that it converts estrogens to androgens, converts to estrogens, androgens to estrogens to help vaginal dryness and thickness. There's limited research on, can this help with urinary tract infections? So does it help the bladder symptoms? Limited data on that. So we really don't know a lot beyond that. Ospimifene, marketed as Ospina, is an oral medication you take by mouth every day. It is FDA approved for vaginal dryness and painful sex. And so then you also have testosterone vaginal cream, which is off-label, not FDA approved for women for use. And we don't really know if testosterone, ospimifene, and again, the DHEA can help with urinary tract symptoms and recurrent UTIs that we often see in the post-menopause. So we need more data, need more information on those, but they can help the potentially vaginal dryness, potentially. Your hormonal preparations, again, also prescriptive. You have lots of options. You can try vaginal estrogen cream a couple of times a week. You can try a 90-day vaginal ring, a little ring made of silicone, I believe, that stays in the vagina for 3 months, and take it out and put a new one in. You can try suppositories. You can try that are also 2 times a week. And then you can also try a vaginal tablet. It looks like just a little tablet that you'd take by mouth, but it goes in the vagina with the use of a little plunger. Those all kinds of different preparations for vaginal dryness. These preparations here are all local, not systemically absorbed. So important for me to make sure that you understand that. So when we start talking about what are my risks for cancer and things like that, it's important that I tell you these are local. And the governing body that sort of helps me, called the American College of Obstetricians and Gynecologists, has come out with a position statement that local does not increase cancer risk. It does not absorb into our bloodstream. It could help vaginal dryness, pain with sex, could help recurrent urinary tract infections, which I see a ton of in my practice. And so these things can help those issues without absorbing and giving us the worry. So when I talked about hormone replacement therapy earlier, and we really don't want women 10 years or 60 years of age or 10 years beyond the menopause starting hormone replacement therapy, This is not hormone replacement therapy because it is local. So it's not going to help those vasomotor symptoms. Okay, it's only going to help GSM, dryness. All right, and so this is, again, the governing body that sort of keeps me in check. And then I did want to also briefly mention vaginal laser therapy. It's gaining a lot of traction. There's a lot of information being put out there. The vaginal laser therapy that we use, it's carbon dioxide laser, and it's called Mona Lisa Touch. That's the marketed name. It is in use. The problem with it is it's not typically paid for by insurances. And so it's a huge cost for women. It can be anywhere from $1,500 to $2,500. It's a series of treatments, and it is FDA approved for vaginal dryness and atrophy. They're looking at research into this vaginal laser therapy for incontinence, and they're also looking at it for other kinds of bladder symptoms, and can it help urinary tract infections? So to TBD on that. The erbium laser called the Yaz, I do not use. I'm not very familiar with it. It's more for the facial wrinkles and help with that. But it's important to understand there's very little data on that. And so for that to be used in the vulvovaginal area, we don't have any data on that. And so I do caution people on that particular therapy. But the Mona Lisa, the touch, the energy-based therapy that's fractional CO2 laser is FDA approved for atrophy. Super expensive, might be of help. Stay tuned on whether or not, we'll see as the years go by, of whether or not there's good data on urinary tract symptoms that are affected, or the urinary tract that's affected with GSM. And so I did want to make sure I go back to the NAMS position statement to help you understand, again, key points on vasomotor symptom treatment, and also, again, systemic therapy. The only thing that is going to help vasomotor symptoms, the hot flashes, is something that is absorbed. There's not really anything out there that's local. There are some over-the-counter products that you can try. Very little data, but there are over-the-counter products out there, and I'll mention those here in just a second. Hormone therapy, hormone replacement therapy remains the absolute best treatment for hot flashes. And this isn't the focus of our talk, but hormone replacement therapy still does remain the best treatment for prevention of bone loss and subsequent fracture that, again, becomes more problematic as we age and get farther away from that menopause point. Hormone replacement therapy is a personal decision. Not every woman needs to be on hormone replacement therapy. And again, it's an opportunity to have a good conversation with your provider on that, and what are the options and what could help, whether it's hormone replacement therapy or something else. And we'll talk about that in a second. Benefits do exceed the risks. Where, again, pendulum is swung back more toward a more middle ground. Benefits typically do exceed risks. But again, as I mentioned earlier, that timeline of initiation. There are also not just by mouth options. There's transdermal, or meaning patch type options. And there's also lower dose options. There's systemic absorbed options that can be put into the vagina in the form of a different kind of ring, not that local ring that I talked about. And so it's super important to understand that you have different ways to have this medication delivered that might also have reduced risk or reduced concern for stroke, heart attack, cancers. So again, an opportunity to have a really good conversation with your provider. There are also menopause specialists out there. NAMS offers a menopause certification. And so if you're looking for a menopause specialist who this is what they do, you could always go to the NAMS website. They keep a directory of clinicians who are NAMS certified. And that might help guide you so that you can look for somebody who can have a really good conversation with about this. And there's so many choices, so many choices. As I mentioned, there's oral, there's transdermal, patch, there's vaginal, systemic, and then you get to, what's conjugated estrogen, what's bioidentical, on and on and on it goes. What's pregnant, what comes from pregnant urine, pregnant mare's urine, you just go on and on and on. And what dose is right for me? The main thing that we recommend is looking at dose, the lowest dose that is going to also help your symptoms. So you don't need to be on the highest dose. So we typically say the lowest dose that also helps your symptoms. And if we have to titrate up, maybe we do that depending on symptom resolution or improvements. And not everything works for everybody. And so again, have that conversation. I encourage you. And we still have so many choices. There's just so many choices. There's non-hormonal over-the-counter options, and there's non-hormonal prescriptive options. A couple of the pictures here that I've put out, we've heard about Estroven, black cohosh forever. I don't frown against that. What I do tell women is if it works, if it helps, okay. It's not going to do anything to protect the bones. So I really want to make sure women understand that just because this says Estroven doesn't mean that it is estrogen, and it doesn't mean it's going to protect other things that do occur as we age. But it might help. It might help hot flashes. Black cohosh might help. The remifemin might help. So sure, I don't tell women don't try it. What I do tell women, not a lot of data. We need more data. And so there's not a lot of information for us out there, unfortunately. Your prescriptive non-hormonal choices are your what we call SSRIs. SSRIs are antidepressants. And that particular medication, those particular medications, there is one medication that is indeed FDA approved for hot flashes, and that's called paroxetine. It is the one medication that is FDA approved. We also have what's called SNRIs that might help hot flashes, but it would be off-label use. Gabapentin, clonidine, those are prescriptive medications for other concerns that also, again, off-label use, but might help hot flashes. They are prescriptive, so you would need a prescription from your clinician, but they're not hormonal. So important to understand that. You have other options over the counter. You've got the ginkgo biloba. St. John's wort is an herb that is also marketed for mild depression, but we see that there is some potential benefit for hot flashes with it. Your ginseng. I have a lot of patients asking me a lot of questions about ashwagandha. We, again, don't have data, but it might be of help with reduction of those hot flashes. Okay. All righty. And so I think, yep, that is the end of what I've got. It was quick, super, super rapid fire. But hopefully informative. And so I'm going to go ahead and turn it back over to Jeff to see if we have any questions and have more conversation here. Oh, Jeff, I don't hear you.
Thank you so much, Amy. That was awesome. I was muting myself so that hopefully you didn't hear rustling papers, because I had so many things I was writing down and thinking about when you were talking, because there's so much to talk about with this. And my friends have brought up questions as well as my patients. So I think it's interesting too. So when she's saying over and over the data, it's the evidence, the science to prove. Have we had double-blind studies? Do we know for sure this works? Safety and efficacy. That's what we're trying to. Does it work? Efficacy and safety. And so we just don't have a lot of data on a lot of those things. It doesn't mean they might not be okay to try. You have to make that choice for yourself. So I think that's a really good thing to remember. And I know for so long, estrogen was like a dirty word, because they kind of put everybody on it, all these women, inappropriate women who shouldn't have been on it. They didn't follow, they weren't looking at guidelines of starting before 60, the 10, all the rules that you said are so important so that you don't have those risks, and that the benefits outweigh the risks, so that the pros outweigh the cons. So that's why now you're like, well, why are they talking about this now? This is why we're talking about this now, because the pendulum has swung back to systemic. For the right woman, the benefits outweigh the risks. And systemic is different. And sometimes even when women use the systemic, they still need the local estradiol as well, because it doesn't get down there to help with the genitourinary system, right?
That is absolutely correct. And a
So
lot of women too, because they want to be on as low a dose systemically as possible to help their hot flashes, we do still see some of those GSM kinds of symptoms because we are using lower doses. So sometimes we have to, pivot a little bit.
yes. So when you think about it, so I want you to think about your female anatomy. When you separate the labia and look inside labia majora and labia minora, that whole area there, you have the urethra, you have the vestibule area just outside of the vagina, that vulva area, all of that area is highly estrogen dependent. And so that's why you'll hear Dr. Hull talk about, here's the thing. You can have urinary tract infections. You can have urinary incontinence because that tissue is also affected and can atrophy or shrink. Different changes can occur, causing urinary tract infections, causing urinary incontinence, causing pain with sex. I've literally, and I'm sure you have, had patients say, it feels like a knife going into the vagina rather than a penis.
Yes, absolutely.
It is profound for some women. And think about it, people. We're talking about 2/3 of women report this in some studies. And remember, not everybody wants to talk about this. So I think it's underreported. So a lot of women are suffering. I'm sure you've seen too, where some sclerosis even occur where the vagina can close.
Mm-hmm.
So this can be a significant problem. And like you said, so the local treatment works right in that area, the genitourinary area. And that's why we were focused a little more on that and doesn't have the systemic absorption. Let's talk about that for a minute. Just looking on GoodRx, and I don't know if you saw, but you can get the estradiol generic version with GoodRx without your having a prescription plan or anything like that for about $26 to $40 a tube. And that tube will last you because remember, you use it twice a month. Couple things
Twice a week.
Yep. Twice a week. Yes, in the beginning, you use it for about 10 to 14 days straight, right? And then 2 times a week. So you got to set it in your phone, Mondays and Thursdays or whatever, so you don't forget your twice a week, but twice a week. And usually you'll use a gram of that depending on your prescription.
Mm-hmm.
If you find I found some patients are like, gosh, that oozes and stuff. And I'll tell them drop to a half a gram. You don't have to use the whole gram. A little goes a long way with the cream, right?
Exactly. And a lot of times, these preparations come with applicators, and a lot of times women do not like the applicator. It's messy, it is wasteful, and then it's hard to clean that applicator. And so I tell women too, put it on your fingertip, half of an inch.
Mm-hmm.
You can look at the applicator and see how much a half of a gram or a gram is because it's marked on the applicator, and then measure that against your finger and you'll know how much to use. And I tell them, rub all that skin, rub it in like a lotion inside and outside, typically at night, because then we're off our feet and it's not all goopy. And then, also because we're not going to the bathroom as often, might get up once, maybe twice a night, but usually we're not getting up and we're not wiping it all off. And it helps it to be less wasteful to use the fingertip method.
I teach it same thing. Right on the tip of your finger. You put it right here on the ball of your finger. Don't get it under your fingernail. Put it on the ball of your finger. And then they just apply it. Like you said, just outside, just inside. And a lot of women like that technique if the applicator's okay. Remember, the ring, the cream, and the tablet, the Cochrane reviews, the science says they all work equally well. So whatever you prefer. Tablet, same thing. You take it for those 10 to 14 days straight and then twice a week, right? Little
Exactly.
goes a long way. The tablet is a very set dose. So sometimes people who are worried, like if I have a cancer patient, a breast cancer patient, the oncologist and I will agree, the best thing is to use the tablet, because for sure you're getting a very accurate same dose all the time, and it's a very low non-systemic dose.
Exactly. And you mentioned the breast cancer patients. Some of those women are all on what's called aromatase inhibitors. And so not only are they now hypoestrogenic because maybe they're menopausal, but then they're really hypoestrogenic because it just takes all the estrogen out of the tissue, anything, anywhere in the body, because it's designed to, reduce that cancer risk, that breast cancer risk. So those medicines can be quite problematic. And then so women have symptoms here that go to here. And it's like, oh my gosh.
Yes.
So we have to really try to tailor that treatment to that population.
Yes, definitely. And then you saw, even if you're really afraid of that estrogen word, the E word, there are non-hormonal things that you can try. There are a lot of different things out there that sometimes may be worth a try as well. And you don't have to. It is your body and your choice whether you want to use an estrogen supplement. We had a question come in, and it was asking your thoughts on calcium supplements for bone health, because you talked a lot about bone health, and we know after menopause, bone osteoporosis, osteopenia, it becomes an issue. What are your thoughts?
Absolutely. I recommend that every woman be on a calcium supplement, but also vitamin D, specifically D3. So it's not just the calcium. You need both calcium and the vitamin D3. It can be beneficial. The problem with calcium and vitamin D, I think that's not understood, is once a woman has osteoporosis, taking a lot of calcium and vitamin D isn't going to fix that problem. It's not going to make it go backward. And that's where prescriptive medication is more necessary there. And there's another class of medication called bisphosphonates. And those medications help to sort of regrow that bone, if you will, for lack of a better way to really describe it, to help that osteoporosis. But even those women may still need to be on calcium and vitamin D supplementation.
And followed with DEXA scans and things to look at their bone health, right?
Yes, absolutely.
So advocate for yourself. I love how you talked about ask about it, bring it up. Same thing with bone health. Ask about DEXA scans. Are they watching your bone health? Are they measuring your bone health and looking at it, and then making sure they get ahead of it rather than behind it, because that's important as well. It's been so great, and it was awesome. You provided such great information, all evidence-based. I am so excited to have had you here this evening. And listeners, I know it's been a lot to unpack. So let's ground ourselves a little. You know how we like to do this at the end, towards the end of the show. Well, let's ground ourselves a little. We will end with a grounding exercise. But first, real quick, Vic, can you show us what's coming up next week on Dr. Jeff Talks About Sex and Intimacy?
In this episode, expert sex therapist and couples counselor Dr. Jennifer Littner joins Dr. Jeff. She will explore how to keep the flame of passion alive in relationships. Discover the common challenges couples face in maintaining intimacy and desire. Learn practical tips to reignite the spark and deepen your connection. Join us next week to learn more.
Well, it has been an awesome, packed episode, and maybe it overwhelmed you a little. So I want you to stop. Let's end with a grounding exercise. I want you to work on some breathing with me. You're going to take a breath in for 4 or 5 counts, and then you're going to gently exhale for 4 or 5 counts. In. Breathe from the chest and the diaphragm. Fill your lungs completely. And as you exhale, just feel yourself sink and relax and melt into your chair. 4 or 5 counts out. 4 to 5 counts in. Gently exhale for 4 to 5 counts. And as you breathe, remind yourself, I am whole. I am worthy. I am enough, just as I am. My challenges do not define me. They shape me. I release unworthiness and embrace my true self with love and compassion. Carry this affirmation with you as you move through your day or night, knowing that you are truly deserving of love, connection, and joy. I thank our special guest this evening, Dr. Amy Hull. She provided you some phenomenal information. Any final thoughts or anything else would like to tell our audience, Amy?
Well, first of all, don't be afraid to ask and advocate for yourself. Super important, because a lot of times, clinicians are busy. They're not wanting to ask the question. They're just busy. They forget. So, keep them in line. Ask the question. Don't be afraid.
Definitely. No one advocates for you like you. You are your own best advocate. So don't forget that. I love that message. We're going to leave you with that. And thank you all so much for joining us this evening, and have a blessed one.